in talking about agents which are not chemotherapy and work in hairy cell, when would you use ibrutinib in the relapse refractory setting?
I have used ibrutinib only on a clinical trial setting, and in that setting it has shown activity. It's not highly active and does not produce complete morphological remissions in most patients, but it does produce durable benefit for most patients that have used it, and particularly in variant hairy cell leukemia. In a few patients that I've used it, I've seen durable clinical benefit. It is an oral agent, and clearly, again, it has to be used continuously. And also, there are some side effects which are not major. As you know, this drug is being effectively used almost now universally in treating chronic lymphocytic leukemia, so it's a tolerable agent. But in general, I don't think the responses in hairy cell leukemia are as remarkable as those we see in CLL.
And one of the things we see is the time it takes to get the best response can be a long time. Some of these patients can take up to a year or more to develop a complete remission. The interesting thing is, before they respond, and this may be in the first few months of treatment, their normal blood counts can actually get worse. And so you don't want to start someone on ibrutinib, I think, who has very, very poor blood counts and is in danger of having neutropenic infections that are potentially lethal, because that patient may actually get worse before they get better. And ibrutinib is known to increase the risk of infection and bleeding. However, we have also seen patients who have classic hairy cell leukemia that do very well on this drug, and over a long period of time, they can achieve complete remissions. We have not I've not personally seen patients with classic hairy cell leukemia become MRD free. These patients generally have MRD that's visible in not only in the bone marrow aspirate or bone marrow biopsy, but also in the blood. However, we did see a patient with hairy cell variant who had large lymph nodes that got smaller and smaller to the point where we can no longer feel the lymph nodes. So that patient, because he had a lot of rituximab before the ibrutinib, could not detect hairy cell only by these lymph nodes. Now this patient is technically MRD free. So patients can have some benefit with ibrutinib, both the hairy cell classic and hairy cell variant, although I agree that this drug seems to be much more effective in patients with classic rather than variant hairy cell.
So last and not least is a drug that you and your group were instrumental in development, and essentially it is a product of research at the NIH for many years, and that is the anti-CD22 recombinant immunotoxin, moxetumomab. And since I believe you're the person who has worked most extensively with this drug, perhaps you could give us your take on its role and its activity, and its also importantly side effects. Okay,
so let me start by just going way back to what is an immunotoxin, I work with Ira Paston at the NIH, he and Dr. David Fitzgerald, even before 1989, when I started in the lab, had been working on immunotoxins, which are proteins that can kill cells through a toxin action. They the protein that we use in the lab is called Pseudomonas exotoxin, and the way it works is it binds to the surface of the cell. It goes inside through receptor-mediated endocytosis, and then it's cleaved, and then a fragment of the toxin gets to the cytoplasm where one molecule should be sufficient to kill a cell. This has been found similarly for diphtheria toxin, which has a similar mechanism. It inhibits ADP ribosylates elongation factor 2, and this causes apoptotic cell death. So that's the mechanism of action, and David Fitzgerald back in the 90s constructed a anti-CD22 recombinant immunotoxin, and that one was called BL22. We tested that in patients with hairy cell leukemia, found responses, and moxetumomab pseudotox, which originally was called HA22, is actually a high affinity version of BL22, which binds 14-fold better. It's more selective for CD22 positive cells. And as we know, hairy cell expresses CD22 in very high amounts, not quite as high as CD20, but very high amounts. And the nice thing is that patients who've had CD20-directed therapy, including rituximab, where the rituximab may be still on their hairy cells, the CD22 is unblocked and can be accessible to the moxi. And so we called moxetumomab pseudotox moxi.